Hi, this is Dr. Baksh. Let's talk about infective endocarditis today. Infective, it means it's an infection of the endocardium. It is most commonly caused by bacteria. I mean, there are other types of endocarditis as well, like rheumatic and Libman-Sachs, but today we'll be talking about the infective. Infective endocarditis is basically an infection involving the endocardial surface of the heart, including the valvular structures, the chorda tendineae, or sites of septal defects. Men are affected 2.5 times more than the women, and it's more common in older age. So let's go over the anatomy of the heart. As you can see from the outside, we have the pericardium, the epicardium, the thick muscular layer myocardium, and the innermost lining endocardium layer. Histologically, it's composed of loose connective tissue and simple squamous epithelium, which is same as the blood vessels. Let's look at some of the risk factors, which include prior congenital heart disease or rheumatic heart disease, if any dental procedure is done before, or if there's any urinary tract or intestinal tract procedure. IV drug abuse, it's a high risk group. Central venous catheter or prosthetic heart valves. So let's look at the causes. The most common pathogen is Streptococcus viridans, and it causes a subacute type of infection. Now, Staph aureus, it's less common, but it commonly causes the acute type, which is more severe. We will talk about it in detail. Then we have Streptococcus epidermidis, Streptococcus bovis as well, which is associated with the colorectal cancer. Other than bacteria, it can also be caused by fungus. Then we have Coxella burnetii. We also have the HACER group of organisms. These are basically organisms which are difficult to culture. So usually the blood cultures come back as negative, which includes Haemophilus, Actinobacillus, Cardiobacterium, Echinella, and Kingella species. Okay, so now the classification. It's classified clinically into two types, acute and subacute. In acute, it develops rapidly over a period of days to weeks, and there's very high fever in it. The patient is generally quite unwell, and it quickly progresses to damage to cardiac structures. While on the other hand, subacute, it develops over the course of weeks to months, and the patient often complain of only vague symptoms. Okay, so let's go with the pathophysiology. The pathophysiology of infective endocarditis, it is actually quite interesting. So what happens is, with the turbulent blood flow, the endocardium can get damaged. So there's a break in the continuity of the endothelium layer. So let's suppose if this is an endothelium, and if any break happens due to turbulent blood flow, so what happens in this part is the platelets and fibrin, they begin to adhere over here. Once they start depositing over here, they can trap bacteria. Now, where does the bacteria come from? There is transient bacteremia. So this is not septicemia. Bacteremia simply means there is bacteria present in the blood. It can happen in cases like after a dental procedure, or if it's an open wound where bacteria comes into the bloodstream transiently, because it quickly gets destroyed by the immune response of the body. So, however, if they during the transient bacteremia, this bacteria, once it goes through this part, the bacteria can get trapped over here. So once we have a bacteria getting trapped onto the endothelium, it causes proliferation of pathogens, and also more fibrin gets deposited. So it kind of forms a vegetation. So these are the vegetations basically, which is a complex of bacteria which is rapidly multiplying, and deposition of fibrin. This type of pathology is commonly seen in subacute type. But in the acute type, what happens is the organisms, they are already very highly virulent. So what these pathogens do, they directly invade the endothelial cells. Even if it's a healthy endothelial cells, they directly invade, and it causes expression of adhesion molecules as well as the prothrombotic factors. So they form vegetations directly. Okay, so another very important point in the pathology here is that these vegetations basically, they can detach from here. This vegetation can detach and then it can move into the bloodstream. Once it detaches, we call it as a septic emboli. So if this septic emboli, let's say if it goes into the fingernails, it can cause splinter hemorrhages. If it goes into the palms and soles of hands and feet, it can cause Janeway lesions or ocular nodes as well. Another way is if from these vegetations, antigens can break away. So when these antigens go into the bloodstream, they combine with antibody and form antigen-antibody complex. Now these antigen-antibody complex get deposited in various parts of the body. They get deposited into the eye and form road spots, or in the kidneys causing glomerulonephritis. So if we look at the clinical features, the patient develops fever. It's usually a high-grade fever due to bacteremia. There is murmur. This is basically due to damage to the valvular structures. Anemia of chronic disease, splinter hemorrhages, which I just mentioned, Janeway lesions, these are non-tender, ocular nodes, these are painful, road spots in the eye, which are diagnosed by fundoscopy, can cause glomerulonephritis, and splenomegaly, which is seen in the subacute cases. So these are the splinter hemorrhages we can see. The ocular nodes, which are very painful, erythematous nodules. Janeway lesions, these are not elevated, these are macules and non-painful on the palms and soles of hand and feet. And rot spots in the eye, you can see here. Now let's come to the diagnostic testing. Now the diagnostic tests involve ordering a CBC, a serum chemistry panel with glucose, a urine analysis, but these two are the most important for diagnosis. It's very high yield, the blood cultures. We order 3 blood cultures, which should be 1 hour apart and before the start of antibiotics. This is very important because a very common cause of negative blood cultures is starting the antibiotics before the blood cultures. And another thing is echocardiography, looking at the heart structure through an ultrasound. Depending upon the case, we can use either approach, transthoracic or transesophageal echocardiography. We do an R effector as well because it is a part of minor criteria of Duke's criteria. Okay, so let's talk about Duke's criteria. This is a criteria which helps us in confirming the diagnosis of infective endocarditis. It is made up of major and minor criteria. So in order to have a confirmed diagnosis, it should be 2 major criteria, or 1 major plus 3 minor, or 5 minor criteria should be fulfilled. So let's look at the major criteria first. Major criteria includes only 2 points. There should be positive blood culture. It could be 2 separate blood cultures for a typical pathogen or 2 or more for the less typical pathogens. And the second point is there's evidence of endocardial involvement, which we see it on echocardiography. It can be an oscillating intercardiac mass on the valve, an abscess, new partial descent of a prosthetic valve, or new valvular regurgitation. Now, the minor criteria includes if there's a predisposing heart condition or a history of IV drug use, fever over 38 degrees centigrade. There could be a vascular phenomena or immunological phenomena, which we have mentioned, like glomerulonephritis, ocular nodes, rot spots, eye effector. For the vascular phenomena, it could be any major arterial emboli or even pulmonary infarcts, which are basically due to these vegetations, due to the septic emboli, because it can go anywhere into the body through the bloodstream, and it can cause infarcts. Conjunctival hemorrhage, Janeway lesions, microbiological evidence, like there's positive blood culture, but it's not meeting the major criteria, or if we see changes on the echocardiogram, which are consistent with the infective endocarditis, but still not meeting the major criteria. So now let's go over the treatment. So we need to start immediate antibiotic therapy as soon as the diagnosis is confirmed. And the final selection of antibiotic, it depends upon what type of organism is isolated and the sensitivity test. The treatment duration usually lasts about 4 to 6 weeks. And a good initial impact therapy, it is flucloxacillin or methicillin plus gentamicin or vancomycin. Now let's talk about treatment guidelines, which vary from country to country. But for virulent streptococcus, it's good if we use ceftriaxone for 4 weeks. For Staph aureus, sensitive type, we can use oxacillin, neficillin, or cefazolin for 6 weeks. If it's resistant Staphylococcus or Staphylococcus epidermidis, we use vancomycin or daptomycin for 6 weeks. For fungal, as you can see, we give amphotericin and valve replacement. It's very important. For HISEC organisms, we can give ceftriaxone. Indications for surgery. The two most strongest indicator for surgery are if there is an acute valve rupture or if there is very severe congestive heart failure. These two are very high yield points. Other than that, if it's a fungal endocarditis or even in cases of prosthetic heart valves, we go for surgery, adjuvant to antibiotic therapy as well. Now for prophylaxis, we need to establish the need for prophylaxis. One, there should be a significant cardiac defect, like a prosthetic heart valve or previous history of endocarditis, unrepaired cyanotic heart disease, etc. And there's a risk of bacteremia during the procedure, like if it's a dental work with blood, a respiratory tract surgery which produces bacteremia. Now for the prophylaxis, the best initial management is to give amoxicillin before the procedure. Now just to summarize some of the clinical features, the presentation is very non-specific. It commonly includes fever. We need to see the historical sources of bacteremia as well. The symptoms are often very subtle, but the examination may give some points like cardiac murmur, ocular nodes, hot spots or Janeway lesions, or splinter hemorrhages. For the diagnosis, 3 sets of blood cultures, it's very important to take before the start of antibiotic therapy. An echocardiogram should be done in all cases. And the treatment is guided by presentation, the clinical findings, and the organism virulence. So that's all for this topic. Do like the video and gives us a thumbs up, and do subscribe.